conference.
Perfect. Beautiful. Thank you, Matt. So, hi, everybody. Good afternoon. Good morning for Andre. Welcome, everybody, to the first grand round for the month of December. And thanks God, 2020 is coming to an end. Hopefully, 2021 will be mellower and milder and nicer. So, I have the utmost pleasure to introduce you to one of the most fantastic academicians and teachers in medicine that I have known in a long time, with Dr. Andrew Mansour. Dr. Mansour is an internist and a hospitalist. He is an assistant professor of medicine at the Division of Hospital Medicine at Oregon Health State University. Dr. Mansour, he is well known in all the social media, Twitter, and all the social media in medical education for all his innovative techniques for revitalizing the love for physical diagnosis and good clinical approach to patient at the bedside. I've been learning tons out from him, and I am sharing my learning with my internal medicine residents here, which make me look like a rock star, but I disclose who's my source of information. He wrote a beautiful book called Framework for Internal Medicine, which I truly would recommend everybody to have that book in your shelves, because it's really a beautiful um, tool in the armamentarium for studying, for refreshing things, and of course for teaching our residents how to approach complex differential diagnosis. So without any further ado, so Dr. Mansour has getting well known for his bedside manners and evaluating the jugular venous pulse as one of the most probably forgotten physical findings that we can actually see. And I have seen this presentation a couple of times, and I'm just so surprised how I changed my own physical diagnosis and my own physical examination, and really enhancing the quality and really finding those JVPs that were very hidden. So without any further ado, you are in for a treat. Please stay. This is worth your time. And Andre, Dr. Mansour, it is a pleasure to have you here, and welcome to the Cleveland Clinic, even if it is virtually.
Thank you so much for that wonderful introduction, Moises, and thank you all for joining, and thank you for having us. And a special thanks to Moises, who I've learned a lot from over the years. He's one of my favorite people that I've never met in my life. I hope someday we can remedy that. But thank you, Moises, for the invitation. This presentation is called, and actually I'm gonna mute my video feed here. And actually, I would ask that you all do the same, just because this presentation is quite video heavy, and we wouldn't want your video feed to compete with the videos in the presentation. And also, that reminds me, if you have a device that can handle video well, like a computer or a tablet, sometimes the phone works, but if you're calling in, I hope that you can switch over to a device that can handle video, because the presentation is quite video heavy. This presentation is called The Art and Science of the Jugular Venous Pulse. And it would not have been possible without Joseph Nugent, who's a medical student at OHSU, who created the annotated videos in this presentation that truly make it unique. And the work that we've done in this presentation is part of a larger project that Joe, I, and a few others have been working on for a number of years, called Physical Diagnosis PDX. It's a website. It's a free website. If you like what you see in this presentation, you'll love the website. I like to begin with a quote from prominent heart failure physician Carl Lear, who has written extensively on the importance of physical diagnosis. He writes, "The inability to properly assess the pressure level and wave contour of the internal jugular veins should encourage the cardiologist interested in heart failure to either learn and develop skill in this component of the physical examination or move to another area of cardiovascular medicine." And we love this quote, could not agree with it more. And while he was addressing cardiologists, we believe this quote is even more applicable to the general internal medicine clinician, especially the hospitalist. Our approach to the jugular venous pulse is separated into three components, and they're all related. Component number one is identification of the jugular venous pulse, and that's 90% of the battle. From there, performing then a quantitative assessment and then a qualitative assessment. We'll talk about each of these components in some detail, and then we'll bring it all together with a sort of a fun multimedia quiz at the end. And by the way, feel free to use the chat to ask questions or to answer questions that I asked during the presentation. Just for the sake of time, we'll probably save answers to those questions until the end of the presentation, but please feel free to ask questions throughout the talk. Section 1 is identification of the jugular venous pulse. Again, probably the most important component, because without it, components 2 and 3 cannot even be attempted. You will often hear from trainees and even other colleagues that the jugular venous pulse wasn't visible in a patient for X or Y reason. Usually it's because of a large neck or the presence of a beard. In our experience, the jugular venous pulse is visible in the vast majority of patients. You just have to know where to look and how to find it. So where should we look for the jugular venous pulse? Well, the go-to place, the place that you should go to first, is the right internal jugular vein. It's ideal because of its direct route down into the right atrium. If the right internal jugular vein is not available, you should go to the left internal jugular vein next. And by the way, when we talk about the internal jugular veins, we're not actually visualizing the blood vessels themselves. We're visualizing the movement of the skin that overlies the vessels. If neither IJ is available, your third option is the external jugular vein. And unlike the IJ, the EJ is visible in the neck. You can see the vessel itself, much like you can the veins on the back of your hand. If you've exhausted that list and you still can't find the pulse, there are other places to look, which we'll get into later in the talk. So let's talk about the steps to identifying the jugular venous pulse. The first step, and perhaps most important one, is patient positioning. Half the time I walk into a patient's room, they're sort of slouched in bed, and they've got multiple pillows sort of behind their head, and their neck is sort of flexed up against their chest. And if you try to move the back of the bed, it just simply moves their head up and down, and that is not ideal. To remedy that, what I do is I will flatten the bed and I'll help the patient scoot up so that their head is near the top edge of the bed. And now when I move the back of the bed, it moves their neck and torso as one unit. And that's what you want. You want the neck and the torso to be in the same plane, meaning they're at the same angle. You also want the neck to be nice and relaxed. You don't want the sternocleidomastoid muscles to be flexed and in your way. And often that's a matter of either adding or subtracting a pillow to accomplish that. And I find in my experience, it's most often a matter of removing a pillow. After the patient's positioned, now you want to observe the neck. And it may seem unnecessary to sort of single out observation as a separate step here, but we've done that to highlight how important it is. Because the tendency is to evaluate or observe the neck from a perpendicular perspective. And if you do that, you're going to miss subtle movement. You want to approach it from a tangential vantage point. And imagine you're 15 feet away from a wall and you're staring straight at that wall. You're looking at it from a perpendicular. Now imagine you walk up to that wall and you put your right ear against it, and now you're looking down the wall. That's a tangential perspective, and that's how you want to observe the neck. Next, you want to locate movement. And the classic window for locating movement in the neck is between the patient's clavicle and the angle of their jaw. If the pulse is below the clavicle, you're not going to see it. If it's above the jaw, you may see it, but it's not ideal for evaluation. So you want to manipulate the patient's angle to either bring the pulse up from below the clavicle or down from above the jaw and into that window. Once you've found movement, you're not done. You have to then decide, is the movement that I'm seeing venous or is it in fact arterial? And there are a slew of strategies to help determine that. The first thing is the waveform. The arterial waveform has a single peak that is quick and sharp. The venous pulse, on the other hand, is double and it's undulating in nature, meaning it has a soft rise and fall. The most striking feature of the arterial pulse is the outward movement. It's what will really catch your eye with the arterial pulse is the outward movement. It's active. Obviously, what goes out must come back in, but it does so passively. It's a kind of a passive retraction back to baseline. It's hardly noticeable. The venous pulse, on the other hand, what will catch your eye there is the inward movement. The peaks are relatively passive and hard to notice, whereas the troughs are active. It's a sucking in movement, and it will really catch your eye. So, and I've put an asterisk there because that's probably the strategy that I use most frequently. If I'm looking at movement and I see an inward component, I'm done. I know it's venous. The breadth of movement can also be helpful. The arterial pulse tends to be pinpoint, involving a small area of the neck, whereas the venous pulse is diffuse, involving a large area of the neck. The arterial pulse is unaffected by patient position, the respiratory cycle, and abdominal pressure. And the reason that's the case is anatomical. So the reason we see the carotid and feel it where we do, the reason we see the radial pulse and feel it where we do, is because that's where those arteries course closest to the surface of the skin. And that's totally independent of patient position or respiratory cycle and so forth. The venous pulse, on the other hand, will vary with these things. So in terms of patient positioning, imagine you've got a patient at 45 degrees and you see the venous pulse in the middle of their neck. If that patient reclines back, if you recline them back into a more supine position, that pulse is going to climb up the neck anatomically. If you do the opposite and sit them more upright, that pulse will move down the neck anatomically. In terms of the respiratory cycle, when we take a breath in, we decrease our intrathoracic pressure, and that creates a vacuum, and it's going to pull that column of blood down toward the heart. So normally, the jugular venous pulse will move down the neck with inspiration. Sometimes the opposite can occur, where you have a paradoxical rise in jugular venous pressure with inspiration, known as Kussmaul's sign. And we'll get to that later in the talk. But nonetheless, if you see any change in location of the pulse in concert with the respiratory cycle, that should argue for a venous pulse. The venous pulse will move up the neck with abdominal pressure. And finally, the arterial pulse is palpable, whereas the venous pulse is almost always non-palpable with a few exceptions. So I want everybody to imagine that we're at this patient's bedside. And recall the steps that we take when evaluating the neck. The first step is patient positioning. He's at 45 degrees. His neck is nice and relaxed. And we're now observing the neck from a tangential vantage point. And remember, the next step is to locate movement in the neck. And I think that we can all appreciate movement in the upper third of the neck, right in here. And if I were to just describe that, we have to decide now, is that venous or arterial? And if I were to describe this movement, I would say that there is a single peak that is quick and sharp. Obviously, it retracts back to baseline, but it does so subtly and gradually, and there's no active inward component here. And it takes up a relatively small part of the neck. It's almost like you want to put your finger right there, and if you did, you would feel it. It's palpable. These are all the features of an arterial pulse. And Joe has annotated this video for us so we can follow that cursor along the tracing and coordinate it with the movement we're seeing in the neck. So here we go. Boom, boom, boom. I want you to take the movement that you're seeing in this video and directly compare it to the movement that we're going to see in the following video. So here we have a double peak, double trough. It's undulating. It's got a soft rise and fall. The inward movement is what catches my eye here. I can see the peaks, but they're sort of passive and inconspicuous. But that down, down, in, that movement there is quite obvious, and that's what catches our eye. And look how diffuse it is. I can see movement from all the way down here, all the way up the neck. So it's quite diffuse. These are all the features of a venous pulse. And so these two videos are nice examples of kind of comparing and contrasting the arterial and venous pulsations with one another. We mentioned abdominojugular reflex. So this is a physical exam maneuver where you put pressure on the patient's abdomen and you evaluate the effect on the jugular venous pulse. And there are several applications, but the one that I want to focus on is in how it can help you identify the jugular venous pulse. Because remember, we're still talking about component number one, which is identification of the jugular venous pulse. So how can it help you with that? Well, if I'm looking at the neck and I see movement, and I'm not quite sure, is that movement venous or arterial? And I put pressure on the patient's abdomen and that pulse moves up the neck, then I'm much more confident that's a venous pulsation that I'm seeing. And here it is in action. You can see the movement near the cursor. And with abdominal pressure applied right now, you can see that movement climb up the neck. Now it's near the angle of the jaw. We mentioned the order in which you should look for the jugular venous pulse. We talked about the right IJ being most ideal. Sometimes it's not available, whether there's a catheter on that side or sometimes the patient has a thrombus involving that vessel. Sometimes it's not explained. It's just not clear why, but it's not well visualized on the right. You should then go to the left. And this video is simply here to demonstrate the jugular venous pulse on the left side. You can absolutely appreciate it and utilize it here on the left side of the neck. If neither of the IJs are available, what was our third option? Our third option was the external jugular vein, the EJ. And here's a beautiful example of the EJ. It is this visible vein right here in the neck. What I don't like about this video is that it's not filmed from the most attractive vantage point. It's filmed, we're at a perpendicular here, and we already talked about how that's a disadvantage. We can see movement, which is great, but if this video were to kind of span over to the tangential, we would have a much richer experience. But what I do like about this video is that it shows a venous pulse and an arterial pulse side by side, so we can really appreciate the differences between them. Let's focus on the arterial pulse for a moment. Now, this is probably an aneurysmal artery here. And so it probably involves a little bit larger area of the neck than an arterial pulse normally would. But nonetheless, all the other features are classically arterial. There's a single peak that is quick and sharp. It retracts back to baseline, but there's no active inward component. It does take up a relatively smaller area of the neck. Now, compare that with the movement we're seeing just next to it in the venous pulse. This pulse is undulating, it's double. The inward components are what really catch my eye, and look how diffuse it is. I can see movement from here all the way up here. So this is a nice video for sort of comparing the arterial and venous pulsations with one another. Now, if you've looked at the neck, you've looked at the IJs, you can't find it there. You looked at there is no EJ, or you can't find an EJ. Don't stop there. A lot of clinicians would stop there and say that the jugular venous pulse was not visible. And if you do that, you're going to get burned. You're going to get burned because sometimes the central venous pressure is so high that it doesn't drop below the patient's jaw, even with them in the upright position. And so you have to look higher than the neck. And there are a couple of classic locations to look. And one of them is the periauricular area. And I hope that you can all see and appreciate this inward movement here next to the patient's ear. That inward movement of the skin is classic for a venous pulsation. If you don't find it there, look a little bit higher. Sometimes it shows up in the patient's temple, and it's this collapsing movement here that we're looking at. That is the venous pulsation there. If you don't find it there, look even higher. Sometimes it shows up in the patient's forehead. That is the unmistakable collapsing movement of the venous pulse. And in all three of these examples, the clinicians who evaluated these patients said that the jugular venous pulse was not visible, and that's because they failed to look high enough. And that concludes section number 1, which is identification of the jugular venous pulse. Now that we know how to identify it, we're ready to move into component number 2, which is quantitative assessment. This is also known as jugular venous pressure, or JVP. So we've moved from the umbrella term jugular venous pulse to a more specific term, jugular venous pressure, or JVP. When a clinician reports a JVP of 8 centimeters of water or 16 centimeters of water, he or she is reporting a quantitative assessment. We use this every day in the hospital and in the clinics. So it's used on a day-to-day basis. And we should begin by asking the question, what are we measuring? We're measuring right atrial pressure. And before we can talk or interpret a JVP, we have to understand what normal right atrial pressure is. And when measured via catheter in millimeters of mercury, it's less than 6. When measured via exam in centimeters of water, it's less than 8. Why do we care about right atrial pressure? Well, it has tremendous diagnostic utility. When that patient comes to us, that undifferentiated patient comes to us with dyspnea or shortness of breath, the JVP exam is absolutely critical. And at best, will give you a diagnosis right there at the bedside for free. At worst, it will narrow your differential diagnosis. If the JVP is normal, then you've eliminated many of the causes of dyspnea and cardiovascular causes, heart failure, et cetera. Now, beyond its diagnostic utility, we often use the JVP exam to establish and follow volume status in patients who have a known diagnosis of heart failure, who are in the hospital with decompensated heart failure. And that's because of the relationship between volume and pressure. So now that we know what we are measuring and why we're measuring it, we're ready to talk about how we measure it. We want to measure the height of the column of blood that's sitting above the right atrium. That's a manometer, and that will tell us in centimeters of water the pressure of the right atrium. The problem is the right atrium sits in the middle of the chest and we can't see it. So we have to use landmarks that we can see to extrapolate to the right atrium. If we can figure out how high that column is above a landmark, and we know how high that landmark is above the right atrium, then it's simple mathematics to determine how high that column is above the right atrium. The angle of Louis is one such landmark, classically said to be 5 centimeters above the middle of the right atrium in any position. They did a really elegant study in 2002, which is in our references section. They used CT imaging and trigonometry and math that was above my head to determine where that angle of Louis was relative to the right atrium in all positions. And it turns out that 5 centimeters is correct in the supine position up to about 30 degrees, but any more than that, and it becomes more like 8 to 10 centimeters above the right atrium. The clavicles are another landmark that can be used, but only in the upright position where they're 12 to 16 centimeters above the right atrium. So again, if we can determine how high that column is above one of these landmarks, then we use a correction factor to determine how high it is above the right atrium. Textbooks love to use this classic image here with a ruler sort of sitting above the angle of Louis and another straight edge. There's a couple hands involved here, and it looks very cumbersome. And I've personally never done this. I don't think I've ever seen anybody do this, maybe medical students here and there, but this is really not the way that we measure JVP at the bedside. I would encourage you to measure the width of your hand. So my hand, for example, is 8 centimeters wide. And I know that, and I will use my hand in place of that ruler. So I'll take the pinky side or the hypothenar side of my hand, and I'll put that on the angle of Louis. And my thumb is now pointed up to the ceiling, and the palm of my hand is facing the patient's neck. And now I'll simply eyeball where that meniscus is, where that column is relative to my hand. So imagine the patient's in the supine position. So the angle of Louis is 5 centimeters above the right atrium. And if I'm in that position and I see that column near the top of my hand, well, my hand is 8, so it would be 8 plus 5 is 13 centimeters of water. Maybe it's half of my hand. So then I would say, okay, for me, it's 4 plus 5 is 9 centimeters of water. Sometimes it's above my hand, and I'll add my left hand there, and I'll add a second hand, and let's say it's a hand and a half. Well, that would be 12 centimeters for me, plus 5 is 17 centimeters of water, and that's how we measure JVP at the bedside. This data comes from a 1973 study where they directly measured right atrial pressure with a catheter, and they plotted that on the x-axis. And at the same time, they measured pressure within the right IJ, left IJ, and EJ, and they plotted those values on the y-axis. And this data demonstrates two major things. One is that the right IJ is highly reliable for estimating right atrial pressure. This is quite a linear relationship here. The other thing that this demonstrates is that the left IJ and EJ are nearly as reliable as the right IJ. So you should feel comfortable using any of these vessels to estimate central venous pressure or right atrial pressure. So let's put these ideas to practice here. We've got a patient here. She's in good position. We're observing from a tangential perspective, and we see movement all along here, and we're pretty confident that's venous because, number one, look how diffuse it is. We see movement all along here. And look at that inward movement. So we know it's venous. And now our task is to determine what the JVP is. We want to quantify this JVP. So to be honest, if I'm at the bedside here, so I see movement all the way up to the angle of the jaw, but I'm not sure, is it higher than that? To be sure, what I would do if I were at the bedside is I would put this patient in a more upright position to allow that column to fall to maybe the middle or top third of the neck so that I was sure that I was seeing the top of it. But just for the sake of this example, let's assume that the top of it is right here at the angle of the jaw. So if we can figure out, now she's at 45 degrees, so remember the angle of Louis is 8 to 10 above the right atrium. She's a slender woman, so we'll go with 8. So if we can figure out how high this column is above the angle of Louis, we simply add 8 to it, and that's the JVP. And I will tell you that this is 12 centimeters above the angle of Louis. So her JVP would be 12 plus 8 is 20 centimeters of water. Anytime you see indentations like this in a patient's forehead, immediately consider long-standing elevated central venous pressure. Here's the same patient in a more reclined position. You can see those vessels are now engorged with blood. This is a similar patient that I just saw really, I think it was two or 3 months ago on the procedure service. We were asked to come and perform a paracentesis on this patient, and could not help but notice these engorged veins in the temporal area. And in fact, when he turned his head, you could see them all around his head. And here's the associated video. So you can see those engorged vessels. Here's the EJ, it's this hose-like structure here in the neck. Look at the IJ, you can see that collapsing movement there. That's classic venous. If we span to the left, we see similar things. And in addition to that, look in the temple area. See right there, you can see that inward collapsing movement. That is classic venous. He's in the upright position. I turned to his wife and I said, I couldn't help but notice these veins. Have you noticed them? And she said, as a matter of fact, I noticed them 2 or 3 months ago, and I've asked many of his clinicians and doctors about this. And not only were they unable to provide an answer to tell me why these veins were the way they were or suddenly appeared, but they were quite dismissive of the question. They didn't seem interested in the question. Well, we were interested. We were very interested in this question, and we asked the primary team to investigate. And they did a right heart cath. And take a guess. Use the chat. Take a guess how high his right atrial pressure was. Remember, he's in the upright position here. Anybody have a guess? That's exactly right. Nailed it. That is, yeah, 30 millimeters of mercury. And when you do the correction, you guys are both right. When you do the correction and multiply it by 1.36, it's 41 centimeters of water. So this gentleman was walking around with markedly elevated central venous pressure for some months. And he was symptomatic, by the way. And it was simply missed. It was not picked up or observed by any of the clinicians that saw him. And, you know, we've really moved away from the fundamentals of medicine. And, you know, everybody knows how to order a cardiac MRI these days, but not many of us know how to read neck veins anymore. And this diagnosis should have been made months ago. We'd like to see a return to the fundamentals of medicine. Now, if you've looked in the neck and you can't find the jugular venous pulse in the IJ or the EJ, you've looked in the periauricular area, the temple, the forehead, you can't find it anywhere. There is one last place to look, one final refuge, and that is the patient's hand. We're going to let this video reset here and restart, but what you want to do is, not everybody has them, but if you look at the patient's hand and you see engorged veins there, or you see veins at all, then they're a candidate for this. And this video is going to restart here in a moment, and you'll see the veins on the dorsum of his hand are quite visible. Here they are, right here. You can see these veins here. So now what we're going to do is we're going to lift the hand above the level of the central venous pressure, and we'll know we're there because they will collapse. So watch as the hand is raised here. These vessels are beginning to collapse here. They're going, they're gone. They're completely flat right here. So we know we're above central venous pressure. We'll slowly lower the hand down until we reach that moment where those veins begin to fill again, which is already happening. There it is. They're right there. They're full again. So we're going to stop there. Watch what I do with my left hand in the video. I'm going to extrapolate across. And if we can figure out where this is above the right atrium, we can figure out what the right atrial pressure is. He's in the supine position. His angle of Louis is 5 centimeters from his right atrium. And his veins begin to fill again at 20 centimeters above the angle of Louis. So his right atrial pressure is 25. That concludes sections 1 and 2, identification of the jugular venous pulse and quantitative assessment of the jugular venous pulse. We are now ready to move into the third and slightly more sophisticated component, qualitative assessment. It's amazing what can be learned about the heart by looking at the waveform itself. And I see some questions being asked in the chat, and we'll get to that at the end of the talk, just in the interest of time. But please feel free to continue asking questions as we go here. It's amazing what can be learned about the heart by looking at the waveform. And I'll illustrate that point by asking a rhetorical question here. What is Mobitz 1 heart block? I think that we would all answer this question electrocardiographically. We would define it as PR prolongation leading up to dropped QRS complexes on the EKG. And we wouldn't be wrong if we described it that way. But what if I told you that Wenke Bach described Mobitz 1 years before he had EKG even available to him? How did he do this? Well, this is a talk on the jugular venous pulse, so if you're thinking he must use the neck veins, you'd be absolutely right. The question is, how did he use them? And hopefully by the end of this talk, we'll be able to comfortably answer that question. Now, before we can talk about abnormalities of the jugular venous waveform, we have to be intimately familiar with the normal waveform, each component of the normal waveform, and what cardiac events cause each component of the waveform. And here is the normal jugular venous waveform. So let's talk about each component. We'll begin with component number 1, which is the A wave, the first peak in the waveform. The A wave is caused by right atrial contraction. Obviously, when the atrium contracts, pressure is going to build up within it, and that's going to be a positive pressure deflection, and that creates the A wave. When does right atrial contraction occur? It occurs at the very end of diastole when the atrium is trying to squeeze the last bit of blood into the ventricle. And that's important. I like to orient myself early on to the cardiac cycle because it really helps me identify the subsequent components of the waveform and what's causing them, because I can sort of go in order along with the cardiac cycle. So after late diastole, now we're in early systole, and I know what's happening in early systole. We have isovolumetric contraction, the pressure builds up in the ventricle, that's going to slam the tricuspid valve shut, and when the tricuspid valve slams shut, it bulges into the right atrium, and that's going to cause another little pressure blip, and that's the C wave. The C wave, by the way, is not visible at the bedside. After isovolumetric contraction, well, what happens next? Actual mechanical contraction in mid-systole. And when the ventricle contracts, it sort of and contorts down towards the apex. And when it does that, it pulls the floor of the right atrium down towards the apex. And that's going to cause the column of blood to move down. At the same time, the atrium is relaxing. It just contracted and now it's relaxing to start this whole process over again. And obviously when it relaxes, pressure within it's going to go down. So the combination of mechanical ventricular contraction and right atrial relaxation causes the X descent. After mid-systole, the atrium just relaxed. And why did it relax? It relaxed so it could fill with blood again. And as it's filling in late systole, that volume implies pressure. So as it's filling with blood, pressure goes up and that creates the V wave. And then now we're done with systole, we're back in diastole. Now we're in early diastole. What happens there? Well, the tricuspid valve springs open and now the blood is going to passively fill from the right atrium to the right ventricle. And when it loses that volume goes down, so does pressure, and that creates the Y descent. It's absolutely critical to be familiar with each component of the waveform, of the normal waveform, and what causes each component to understand when things go wrong. Let's revisit this video from earlier in the talk, the normal jugular venous pulse. And many people will tell you that the components of the waveform are not visible at the bedside. They are simply a whiteboard phenomenon that we draw on a whiteboard. Don't bother looking for them at the bedside. Well, that is just simply not true. And this video is a good example of that. And Joe has annotated this video for us once again, so we can see the entire tracing. And I think all of us can at the very least appreciate the descents here in this video. So we can pretty clearly see X, Y, X, Y, A, X, V, Y, A, X, V, Y. Here's another video demonstrating each component of the waveform using a Q-tip, and Joe has annotated this video for us as well. I cannot overstate how important it is in any component of the cardiac exam, whether it's cardiac auscultation or evaluating the jugular venous pulse, to know where you are in the cardiac cycle. If you're looking at the jugular venous waveform in a vacuum, it's so hard to know, is that peak that I'm seeing the A or the V? Is that trough the X or the Y? When I'm evaluating the waveform, you will often see me simultaneously palpating the pulse or listening to the heart. And I'm doing that because I'm trying to find a frame of reference for myself to understand, what is that I'm seeing? Is it the A or the V, the X or the Y? And there's one cardiac event in particular that's quite helpful for orienting yourself to the cardiac cycle on the jugular venous waveform, and that is S1, which we know is associated with closure of the tricuspid valve, also occurs at the same time as the peripheral pulse. And what component of the jugular venous waveform is caused by closure of the tricuspid valve? Well, we just talked about that, and that's the C wave, which you can't see at the bedside, but the C wave occurs right in the middle of the X descent. So the X descent occurs right along with S1 and the peripheral pulse. So if we're seeing a trough, that trough the X or the Y, and it's occurring concordant with S1 and the peripheral pulse, we know it's the X descent. If it's discordant with it, it's the Y descent. And let's revisit this video from earlier in the talk where we have a venous pulse next to an arterial pulse. And let's focus on the venous pulse for a moment. And I think we can all appreciate the troughs here. There are two troughs. There's one that's dominant, right there, right there, there. So what if I asked you, is that dominant trough the X or the Y, and how could you tell? Well, if we had the benefit of being at the patient's bedside, we could employ those strategies that we just talked about. We could feel the peripheral pulse, we could listen to S1, and if that trough was concordant with those events, then we would know it was the X. Well, we're not at the bedside here, but we do have the benefit of an arterial pulse right next to the venous pulse here. And I think we can all appreciate, or I hope we can appreciate, that trough, that major trough is occurring at the exact same time as this arterial pulse. So we know that it's the X descent. And that makes sense. The X descent is normally more dominant than the Y. So now we're ready. Now that we know, we're familiar with the normal waveform, we are ready to discuss abnormalities before we get to the quiz. And the top tracing here is one that we're all familiar with. That's the normal waveform. The one below is abnormal. And what's abnormal about it? Well, we've lost our A wave. We have no A wave here. And the X descent is quite diminutive. It's small. And so we have to go back to what causes the A wave, what causes the X descent to understand what's going on here. So the A wave is caused by right atrial contraction, and the X descent is caused at least in part by right atrial relaxation. So what condition is there no coordinated atrial contraction and no atrial relaxation? Well, that's atrial fibrillation. And this will also be occurring in an irregular rhythm. So at the bedside, what you'll see here is simply a descent. You'll just see one descent. And you don't see the C wave, you don't see the X or the V. You will simply see a single descent, a trough, and it will be in an irregular pattern. And don't be fooled. If you see two beats that are close together, some people think, oh, that's by a Y followed by another Y. Let's talk about the giant A wave next. So here we have an A wave that is larger than normal. And again, we have to go back. Well, what causes the A wave? That's right atrial contraction. So what would cause the pressure within the right atrium to be greater than normal during right atrial contraction? Well, that's if you have any resistance to RV filling, and that happens with tricuspid stenosis. That happens when the RV and diastolic pressure is elevated for something like pulmonary hypertension. And so what do you see at the bedside? Here you'll see a peak that will really catch your eye. And that should automatically clue you in to something's not right about this waveform, because normally I don't really see the peaks that well. They're typically inconspicuous. So if you see a peak that really catches your eye, that should clue you in to something is not right about this waveform. So you'll see a peak that catches your eye that is followed by two troughs, and that's important. Keep that in mind. You'll see the large peak and it's followed by two troughs. And the other thing that's important to keep in mind here is the giant A wave occurs with, all right? And so let's move on to the next abnormality, which is the Cannon A wave. So here you have an A wave that's even larger than a giant A wave. So what's worse than contracting against a stenotic tricuspid valve? Well, that's contracting against a totally closed tricuspid valve, which occurs with atrioventricular dissociation. So every once in a while, the atrium is going to contract. The atrium and the ventricles are sort of going at their own rhythm. And every once in a while, you're going to have the atrium contract against a totally closed tricuspid valve, and as you might imagine, that's going to create a large ripple, shock-like wave up the neck. And in between, this is typically intermittent. Not always, but typically it's intermittent. And in between those intermittent Cannon A waves, you're going to get the normal waveform. All right, so this is unlike the giant A wave, which occurs with every beat. Let's go to the next one, which is a CV fusion wave, also known as Lancisi sign. And this is, so here, what's wrong here? Well, we've lost our X descent, and what has replaced it is this giant CV wave followed by a quite augmented Y descent. And this is associated with severe tricuspid regurgitation. It makes sense because during ventricular systole, when the atrium is trying to relax, causing the X descent, you have this giant regurgitant bolus of blood that's going backwards into the right atrium at that moment in time. And that's going to create, as you might imagine, this large pressure wave, followed by the larger Y descent, because now the gradient between the right atrium is much larger. The right atrium plus the regurgitant bolus of blood. And at the bedside, a monophasic wave. You're going to see a large wave followed by a large descent. And unlike the giant A wave, this peak is followed by one descent. Remember, in the giant A wave, it's followed by two descents. The other way you could tell the difference between the two of them is timing. So the CV fusion wave occurs in the middle of systole, and remember, the giant A wave is occurring at the end of diastole. The next abnormality to discuss is the sharp and deep Y descent, also known as Friedrich's sign. And so here we have a Y descent that is quite sharp and deep, and this is associated with constrictive pericarditis and restrictive cardiomyopathy. And the way that I sort of think about this is that when you have constrictive pericarditis, the pericardium is scarred down, it's sort of unyielding, and when the ventricle is filling during early diastole, well, it's going to fill, and it's going to reach a point where it runs into that unyielding pericardium, and it can't fill any longer. And so all the friction has to happen early in diastole. So that's why you get a sharp and deep Y descent. The next abnormality to talk about is the W sign here, where you have a deep X and Y descent. And this is more specific for constriction than the Friedrich sign. And why some patients with constriction develop both sharp and deep X and Y descents rather than simply just a Y descent is not clear, but it's something that we do see, and it's again more specific for constriction. The final tracing to discuss before we get to the fun part here is Kussmaul sign, which we mentioned earlier. So here we have a paradoxical rise in JVP with inspiration, and Normally, when we take a breath in, we decrease our intrathoracic pressure, and that causes a column of blood to suck down towards the heart, and that causes the normal decrease in JVP with inspiration. But remember, when we decrease mediastinal pressure like that with inspiration, we're also mobilizing blood from the legs and elsewhere back to the mediastinum. And if the RV has any compliance issues, if it can't accept that increase in blood return, then that blood has nowhere else to go but up the neck, and that causes Kussmaul sign. So this is not a very specific sign, but it's quite sensitive for RV compliance issues from any cause, whether that's RV failure or tricuspid stenosis, constriction, restriction, and so forth. So now we're ready to get to the quiz mode here. And I just want to say a couple of things before we start. Number one is that you can assume that all the movement that we're seeing in these videos are venous. Okay, I'm going to show you a series of venous waveforms, and we're going to try to identify the qualitative abnormality. The second thing I want to say is that this is hard. It's challenging in large part because we don't have the benefit of being at the patient's bedside, where we could employ the strategies that we talked about to help figure out, what component of the waveform we're seeing at what time. So keep that in mind. But when you look at these videos, I want you to think to yourself, what catches my eye about this waveform? Is it a peak? If it's a peak, that should automatically suggest to you that something is not right about this waveform, because normally the peaks are inconspicuous. So if you see a peak, you're pretty much, your differential is going to be a giant A wave, Canon A wave, CV fusion. And if it's occurring with every beat, that makes a Canon A wave less likely. And so it's either a giant A wave or a CV fusion wave. And from there, you want to ask, how many troughs am I seeing following that peak? Is it 2? In which case it would be a giant A wave. If it's one single trough after the peak, the large peak, that is a CV fusion wave. You should also keep in mind whether the rhythm is regular or not, and also the respiratory variation. All those things will help you. And the final thing that I'll say is that there are some repeats. So just because we see a condition once doesn't mean we won't see it again. So let's get to the quiz. So here's the first video. And feel free to use the chat. And I see, Heather, you're asking a question. Yeah, let's save the questions for the end here. But I want you guys to use the chat to kind of to tell us what qualitative abnormality you think you're seeing here. And so again, remember, we can assume that this is venous. And I'm just going to kind of talk through as there. So catches my actually, but that peak is automatically suggests that something's not normal here. I shouldn't really see a peak that well. And so my differential is giant A, CV fusion, or Canon A. Well, it's happening with every beat. So that makes a Canon A less likely. Plus, it's not a shock or a ripple up the neck. This is kind of an undulating, rolling movement. So doesn't really look like a Canon A wave. So is this a giant A or CV fusion? Well, how many troughs follow that peak? How many do you see? I see one. I see a single peak followed by a single trough. And so this is indeed CV fusion. And you can see a little bit of a stutter step right before that, that wave. You can see a little bit of an A as you follow the tracing. Right there, A, then CV fusion, little a, CV fusion, little a, CV fusion. And this is a gentleman with severe tricuspid regurgitation from dilated cardiomyopathy. Let's go to the next video here. So what do you notice here? Is there some respiratory variation with this? I'm going to play the video here with annotation. You can see the movement right there in the middle of the neck. And when she takes a breath in, watch how it climbs up the neck. Look at that. Look at the EJ fill like a worm there in the neck. So this is Kussmaul sign. This patient actually has 2 signs here. If you notice, look at the X, Y descents. They are quite sharp and deep. So she has the W sign as well. And this is a patient who developed constrictive pericarditis 20 years after heart transplant. It's a rare sort of complication from that procedure. Let's move to the next video. Again, asking the question, what catches your eye here? Is it a peak or a trough? And what catches my eye here is a trough. I see one trough that's quite dominant there, right there, right there, there. So then the next question is that an X or a Y? And if you had the benefit of being at the bedside, you could time it like we talked about and figure out, is it occurring concordant with S1 in the peripheral pulse, in which case it would be an X descent, or is it discordant? Tell you that this trough is discordant with the peripheral pulse and with S1. And so this is indeed Friedrich's sign, or a sharp and deep Y descent. So little x, Y, little x, Y. This is a gentleman that developed subacute or transient constrictive pericarditis after presenting with tamponade, and his constrictive physiology resolved over the subsequent weeks. Let's move to the next video here, again asking the question, what catches my eye about this movement here? Is it a peak or a trough? So I see a peak that really catches my eye. Right there, right there. And so then we know something is not right about this waveform because the peaks are typically inconspicuous. So is this a giant A, CV fusion, or canon A? It's occurring with every beat, so that makes canon less likely. So again, is it a giant A or CV fusion? So then the question is, how many troughs follow that peak? And I see preservation of 2 troughs after that peak. And here you can see it. So there's a AXVY, AXVY, AXVY. This is a young woman who developed severe pulmonary hypertension as a result of methamphetamine use. Let's move to the next video here, which is a repeat of something we saw earlier. And the clue here is that, is there respiratory variation here with this jugular venous pulse? The answer is yes. And, this is another example of, so we can see the movement near the cursor, and when the patient takes a breath in, look how it climbs all the way up the neck to the angle of the jaw. What else do you notice about this patient? This is, see this little marker here on his skin right below the A wave in our logo? That is a radiation tattoo marker. And so that's indicative of prior radiation therapy. And this patient had mediastinal lymphoma when he was a teenager, had radiation therapy for that, and that led to constrictive pericarditis, giving rise to Kussmaul's sign years later. This is one of my favorite videos. Look at this wave, quite obvious, and look at that trough. That trough is really impressive as well. This is another example of CV fusion or Lancisi sign in a patient with severe TR. There's an iatrogenic complication actually from a right heart cath procedure. The catheter damaged his tricuspid valve, and he developed severe TR as a result. Look at that. Again, the CV fusion wave tends to be described as a monophasic wave, even though you can see a little bit of an A. So technically it's biphasic, but really that CV fusion is so dominant that we really just see one peak, one trough. Anytime you see that, that is almost always going to be CV fusion. So this next video is a little bit tough because we didn't talk about this during the talk, but I think that it's really important to discuss. And I'm going to put the annotation on because it's hard to know where she is in the respiratory cycle. But look, there's the movement all the way up at the jaw in expiration or exhalation. When she takes a breath in, it goes all the way down below the clavicle. Some of you might be thinking, well, that's normal. The JVP should go down with inspiration. You'd be right, but only really by a couple centimeters at most. This is like 12, 13 centimeter excursion here. That is not normal. And anybody know what tends to cause this? It's sort of a pseudo elevation in JVP during exhalation. And this can fool you into thinking that the central venous pressure is elevated. I've been fooled by this. And so I thought it was worth putting in the talk. And this is usually caused by lung disease. So a patient generates larger than normal expiratory pressures because of their lung disease, causing a pseudo elevation of the JVP. And look how it goes all the way down below the clavicle during inspiration. This is a patient with COPD here. What's going on in this video? What do we see here? I just see a single trough. That's all I see is a trough, 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 trough. Irregular. It's irregular. And this is the classic waveform for AFib. You don't see the C, the X, or the V. You really just see the Y. And when 2 beats occur right next to each other, you might be fooled into thinking that's an X followed by a Y, but they're just 2 Ys that are close in proximity. This is the classic waveform of AFib. This is another example of Kussmaul's sign. So here we see the pulsation, really the neck veins engorged all the way up to the angle of the jaw when the patient takes a breath in. And this is a woman with constrictive pericarditis. This is another example of CV fusion, or Lancisi's sign, involving the facial vein. It's quite an impressive video. I have not seen the facial vein involved before nor since this case, but this is another example of CV fusion in gentlemen with severe TR. And I'm being mindful of the time. I know we started a little bit late, but I want to make sure that there's time for questions. So I'm just going to move through here to the next video. And this is a tough one. This is a difficult one, but when I look at this, again, ask yourself, what's catching my eye here? Well, there's a peak here that really catches my eye. So I want to know how many troughs follow that peak, and there are two. There's a big A wave here, so a giant A. So AXVY, AXVY. And this is a young man with tricuspid stenosis, giving rise to giant A waves here. Here it is at quarter speed. Joe has done a really amazing job with these videos. This is another example of Kussmaul sign, tidal breathing. We can really appreciate how the waveform goes from the middle of the neck all the way up to the top of the neck with inspiration. And I remember when I was a student being told that, oh, you might see Kussmaul sign maybe once or twice in your career. We see it once or twice a week when I'm on service. These are signs that are not that rare. It's just that we have to look for them. They're there to be seen. Here's the final video. So what do we see here? We see, what I see, is a ripple up the neck intermittently. It's not occurring with every beat. This is a Canon A wave, and there it is right there, followed by a couple of normal beats down here, and there it goes. There it goes. So we'll start over here. There's the ripple, then normal, normal, boom, there it is. And this is a gentleman with complete heart block, giving rise to Canon A waves. I take it back. This is the last video. Maximus from Gladiator, who is not supposed to be alive at this point in the movie. But clearly we see movement in the neck here, so we know that life is still present. And the question is that venous or arterial? This is clearly a venous pulsation. Look how diffuse it is. We really see the inward movement. So this is venous. And Russell Crowe needs to improve his acting a little bit if he's going to convince us that he's dead at this point. If he's going to convince our physical exam experts that he's dead. So let's get back to Wenckebach before close. How did he characterize, or how did he describe Mobitz 1 without an EKG? So let's talk about what is the P, so PR prolongation on EKG. What is the P wave on the EKG? That's atrial depolarization / contraction. And what is that in the neck veins or in the waveform? That's the A wave. How about the R wave on the EKG? Well, that's ventricular depolarization / contraction. What is that in the neck veins? That's the X descent. So he observed AX prolongation leading up to dropped arterial pulses, and that's how he did it. Thank you so much for having us. Here are our references. I'm happy to send this out to anybody who's interested. And if you like what you saw in this presentation, stay tuned for our free website, pdx.com, physical diagnosis PDX. It will have not only jugular venous pulse videos to look at, but other physical findings. We also do a lot of physical diagnosis stuff on social media and YouTube. And that's all I have for you guys to answer questions at this point. So let me go back in the chat here. And okay, so the first question, I like David's comment about he must have been referring to the gentleman with dilated veins all the way up around his head. What was the final diagnosis? Maybe, okay, probably asking about that same patient. And actually, so we were called to do a paracentesis. And what do you think was causing the ascites? Well, it wasn't liver disease, it was heart failure. So he had developed heart failure. He was a gentleman with cancer, and he had undergone treatment with chemotherapy and developed biventricular failure as a result of chemotherapy. And that was a diagnosis which had gone missed by all of his oncologists and everyone else for months before that observation was made. How much time, effort do you place in the use of tangential lighting to help ID the JVP? Yeah, so thanks for asking that, Chris. I don't use that very often. I like natural lighting when I'm evaluating the jugular venous pulse. And again, I think if you'll find that if you assume that tangential vantage point, you're going to pick up subtle movement and probably won't need the light. And that's not to say that I mean, if you find it helpful, then by all means you should use it. It's just not something that I found myself in need of before. But if it helps you, you should absolutely use it. But again, it really taking that tangential vantage point is going to help the most. What is the expected venous wave pattern in SVC obstruction? That's a good question, Sam. I'm not sure I know the answer to that question, but I would imagine that that it would probably blunt the waveform. You know, just because of that obstruction, it will elevate the jugular venous pressure, so you'll see that it's elevated. But the waveform itself, I would imagine, would sort of would be disrupted, just because you're not getting that direct transmission from the right atrium because of that thrombus. Let's see, can large TR confuse you with heart failure? Well, thanks for asking that question. Well, you know, I think that there is sometimes that question that comes up, and, you know, and it's mostly a matter of estimating the central venous pressure in the setting of severe TR, thinking that TR can fool you into thinking that the central venous pressure is higher than it is. And that can happen. I look at where that baseline is before that CV fusion occurs. Where is the venous pulse? Is it low? In which case, it's probably the mean central venous pressure is probably on the low side. But if it starts high, even before that CV fusion wave occurs, then the central venous pressure is probably elevated. That's kind of how I use it. I also use the hand vanes in that setting if I have them to kind of help determine the mean RA pressure in that situation. And usually severe TR is going to go hand in hand with heart failure. It's usually a result of dilated cardiomyopathy. Sometimes it can happen as a primary issue in IV drug users and the like, but sometimes they end up developing right heart failure from that. So that's kind of how I would answer that question. Is it not difficult to get the fulcrum pressure? What do you mean by that, Raghu? In the upright position. Tell me more about what you're asking. And feel free to unmute yourself at this point if you want to ask the question.
And speaking of unmuting, I had muted a couple of folks who were on phone only when we had some feedback earlier in the discussion. So if you're on phone only and would like to ask a question, try *6 to unmute yourself.
Any other questions?
Andre, I have one question. I'm wondering if you can talk a little bit about the reliability of replicating your findings among different clinicians. I'm thinking especially of there was a very lovely Atul Gawande essay years ago in the New Yorker, maybe 15 years ago, on the move in obstetrics from forceps to cesarean sections, and how the drive to increase reproducibility and reliability it led to sort of artisans who were very good at using forceps being kind of relegated to the ash bin of history. I'm wondering if you can talk a little bit about that. I sometimes find it difficult to convince our cardiologists to do a right heart cath even when we have an RVSP. I'm trying to imagine convincing a cardiologist to do a right heart cath based on JVP. How have the reliability and ability to convince other folks of your findings based on the physical exam?
Thanks for asking that, Matt. It's funny that you mentioned that. I recently, in the last couple of months, convinced the cardiology team to do a right heart cath based on the presence of Quincke's pulse in the patient's fingernails, and he ended up having high output heart failure, and the right heart cath demonstrated a cardiac output of 13 liters per minute. But yeah, so to answer the question, this reminds me of another question that comes up, which is the studies of JVP saying that it's a coin flip, et cetera. And that's probably because of the inter-user variability, and probably because they used individuals who weren't well trained in this, medical students, residents. And it would be sort of akin to studying, and and when they do the study, they say, oh, it's a coin flip. The likelihood ratios are low, or whatever the case may be. And I take those numbers with a giant grain of salt. It would be akin to doing a study on CT angiography for the, trying to find out the sensitivity and specificity of that test for PE, and using me as the interpreter of the CTA. Well, it would look like a terrible test because I'm not a radiologist. It takes, years of training, hours of training to be good at reading CTA, and the same is true of the neck veins. So those studies that are often cited are more of an indictment of the users of the test rather than the test itself. And so I would say the same thing. So the venous pulse exam is very reliable and experienced eyes, or with experienced eyes. And it's quite reliable. I mean, all of these findings here, I haven't been in practice that long. All of these videos that you saw in this presentation were all patients that I have seen personally. These are all videos that I took personally. And you even saw one that was just taken 2 months ago when I was on the procedure service, and it was a gentleman with markedly elevated central venous pressure. So these findings are there, and I've found it to be the single most important physical finding in my practice is the jugular venous pulse exam, and it's really helps me quite often every day in my practice. And so yes, while there may be user variability, that I'm not sure what that means in the grand scheme of things. There are people who can play a violin and people who can't. I can't play a violin. That doesn't mean that the violin cannot be played. And so I would say the jugular venous pulse exam is absolutely fantastic, especially for hospitalists, and very useful. And it will be a great service to patients if everyone knew how to read the neck veins. That gentleman was walking around with heart failure for several months before the diagnosis was made, and that really shouldn't happen.
Thank you. Heather has a question about JVD and JVP, and then Moises, I'll let you have the last word before we wrap up.
Heather, I think jugular venous distension is more of a description when the veins are engorged. Like we saw a couple examples in the presentation, but I usually just stick with jugular venous pulse. And I like the acronym JVP to specifically refer to jugular venous pressure, but the umbrella term being jugular venous pulse, because remember, we can do more with the pulse than just measure the pressure. The waveform is really important. And so I like jugular venous pulse. I like JVP for jugular venous pressure. And I almost never use the term JVD. If I do, it's used to just simply refer to engorged and dilated veins.
Well, if there are not more questions, I cannot end up expressing my gratitude to you, Andre, for these outstanding and fantastic grand rounds. And certainly, I think we need more of these. Often our grand rounds end up being an esoteric review of hundreds of different molecular tests and things that we have not been proven yet. A lot of phase 1 research, which is very important, but it's not practical, it's not actionable. And some of the grand round we see end up being, well, that doesn't make me a better internist. I'm probably more knowledgeable, but not to care for my patients. So this is really fundamental. I think we need to go back to basic. We need to go back to the bedside. We need to listen. I can tell you, I have severe sensory neural hearing loss, okay? I need a amplifier in my stethoscope. And you have no idea, based on leveraging my handicap, I put some attention in listening. And I find murmur that have been missed even by cardiology. We get the echocardiogram, we will find something has not been heard by somebody. And also, we are in a very busy time where all the templates already pre-populate the physical exam, and people tend to miss that. And so I think it's very refreshing, it's very humbling, and how much we do not know. And everybody passed the UCML step 1 with a cardiac cycle, but then after they become physician, nobody remembers anything about the jugular wave. So this is like maybe it's a wake-up call, right? We need to stay knowledgeable. We need to enjoy the pleasure of taking care of our patient with a good physiological base examination. always keep learning, always challenge ourselves, and always look for more opportunities to hone the skill. So again, I am very grateful for your outstanding grand round.
Thank you so much, Moises, and I could not agree more with what you said. And I really appreciate the invitation. Thank you guys for having me. Thanks for the excellent questions. And the feedback. I appreciate that so much. Thank you very much.
Without any further ado, Dr. Papa, would you be able to stop the recording? Will be terrific. And